Bismillahirrahmanirrahim. Today we will have case quiz number 7. Case data: 70 years old male with history of travel to India few months ago. The condition started while in India by high-grade fever, skin rash and polyarthralgia. Few weeks later, fever and rash subsided completely, but joint pain persisted and arthritis occurred. So polyarthralgia changed to polyarthritis. Few months later, the patient has symmetrical polyarthritis of small joints in the hand, wrist, and ankle, which fulfill the 2010 ACR EULAR classification criteria for rheumatoid arthritis. The patient, however, was resistant to treatment with steroid up to 20 mg per day, with moderate response to methotrexate full dose 25 mg per week, but he stopped receiving it due to severe gastritis. The investigations of this case showed ESR 56 high, CRB slightly high 13, CBC showed mild anemia, rheumatoid factor was negative, ANA negative, anti-CCB negative, ANCA negative, and musculoskeletal ultrasound showed non-erosive synovitis of small joints of the hand. Non-erosive synovitis of small joints of the hand. In fact, 3 years later, all symptoms recovered completely without treatment. So, what is the diagnosis? The answer is take a deep breath, take a deep breath. You can stop here as usual, and you can, yes, it is going to be clear. The answer is post-chikungunya chronic inflammatory rheumatism. Post-chikungunya chronic inflammatory rheumatism. I mean, it is post-infectious arthritis, a matter of reactive arthritis and so on, but it is due to chikungunya infection. What is this? We will see later. Post-chikungunya chronic inflammatory rheumatism, given the prodromal phase between the acute febrile period and development of inflammatory arthritis following chikungunya exposure, the patient was diagnosed with post-chikungunya chronic inflammatory rheumatism. Chikungunya is an arthropod-borne alpha virus endemic to West Africa. However, outbreaks have been reported along the tropics, around the Indian Ocean, Southeast Asia, and the Americas. It is transmitted among humans via the Aedes mosquito. As its vector, it typically presents as an acute febrile illness following a 2 to 4 day incubation period. Headache, myalgia, gastrointestinal symptoms, and distal arthritis are common associated symptoms that present with abrupt onset. A maculopapular rash may emerge around 3 days following initial symptoms. Chikungunya IgM antibodies may be detected around 5 days from symptoms onset, with combined IgM and IgG antibodies being detected after 10 days. Serum chikungunya IgG antibodies remain elevated thereafter due to acquired immunity to the virus. Chronic arthralgia is a frequent persistent complication following chikungunya infection. However, these musculoskeletal manifestations are widely heterogeneous. Arthritis, arthralgia, enthesiopathy, and tendinitis have been commonly described. The entity most commonly described is a self-limiting, relapsing, remitting migratory arthritis of the ankle, the wrist, and distal hand joint with synovitis. Retrospective data has shown complete resolution in 87.9% of the cases. However, 5.9% were reported to develop a persistent, painful, deforming arthritis. So, the majority of cases will resolve completely within 2 to 3 years, but some cases may continue as deforming arthritis and may resemble rheumatoid arthritis. Post-chikungunya chronic inflammatory arthritis mimics rheumatoid arthritis in that patient develop asymmetric arthritis of the MCB, metacarpophalangeal joints, BIB, proximal interphalangeal joints, wrist, elbows, shoulder, knees, and MTB, metatarsophalangeal joints. The median duration of morning stiffness is around 90 minutes, which is also agree with that of rheumatoid arthritis. DIB joints, however, may be involved in up to 20.5% of cases, which is opposite to that occurring in rheumatoid arthritis, which is very rare to affect DIB. Plain radiographs of affected joints show decreased joint space and periarticular osteopenia with erosions in about 1/3 of patients. Saliva biopsy is negative for chikungunya. It is not a type of reactive. There is no active infection inside the joint. Serology is generally negative for rheumatoid factor, while anti-CCB may be positive in up to 1/2 of the cases, which makes the diagnosis more difficult because this case would fulfill the 2010 and even the 1987 classification criteria for rheumatoid arthritis. Supportive treatment, including anti-inflammatory and analgesic medication, is the mainstay of treatment for post-chikungunya musculoskeletal disorders. However, this is not the case for post-chikungunya chronic inflammatory arthritis. It is suggested that persistence of arthritis after 3 months on corticosteroid underpins a diagnosis of post-chikungunya chronic inflammatory arthritis. Given the post-chikungunya chronic inflammatory arthritis mimics rheumatoid arthritis, the use of disease-modifying anti-rheumatic drugs have been advocated. Methotrexate is considered the first-line treatment for post-chikungunya chronic inflammatory arthritis. High-dose steroid and biological agents may have a role as a second-line therapy. However, steroid-sparing agents should be used whenever possible due to steroid-related adverse effects. So, as a conclusion, this case may resemble rheumatoid arthritis and may even respond to the same treatment of rheumatoid arthritis. The only difference here is the tendency to subside completely without erosions, without deformity, and the patient may be cured completely in the majority of the cases after a while. This while may extend to few years. And finally, thank you very much for your attendance, and we will meet you next time with case quiz number 8. Wassalamu alaikum wa rahmatullahi wa barakatuh.